Hello, my name is Christina Mitchell, and I'm one of the physicians who sees patients as part of the Penn Bone Center. This video is about the use of estrogen and raloxifene as medications to treat osteoporosis. Estrogen, as you know, is one of our main bone building and bone sustaining hormones. We start to deposit bone mineral density in earnest at puberty, when estrogen begins having a major effect on the bones, reach the peak bone mineral density by about the age of 30, at which time estrogen maintains bone mineral density. And it is with the loss of estrogen with menopause that osteoporosis has the potential to develop. So estrogen deficiency is really the primary reason for the development of osteoporosis. Estrogen has been shown to prevent osteoporosis in women in whom non-estrogen medications are not considered appropriate. However, there are major risks associated with the use of estrogen after menopause, including cardiovascular disease and the risk of breast cancer. Current recommendations for the use of estrogen are to use it for the relief of menopausal symptoms, namely vasomotor symptoms, the medical term for hot flashes, in the lowest dose possible for the shortest time possible. Currently, estrogen is not labeled for therapy for osteoporosis because there are other options available which are more effective to reduce the risk of fragility fracture and are not associated with the risks of cardiovascular disease and breast cancer that are associated with estrogen. A similar medication is raloxifene, which is indicated for the prevention and treatment of osteoporosis. This has been shown to reduce the risk of spine fracture, but it has not been shown to have similar efficacy for non-vertebral or hip fracture. It is a selective estrogen receptor modulator, the acronym SERM, which acts like estrogen in the bone to prevent bone breakdown. Interestingly, it has the opposite effect in the breast, where it blocks the estrogen receptor. So it has a positive effect on the estrogen receptor in the bone, but a negative effect on the estrogen receptor in the breast. The dose is 60 milligrams daily by mouth, and this is a pill. It is not indicated for women of childbearing potential, those who have a history of venous thromboembolic disease, namely blood clot of the leg, because this medication is associated with a threefold increase in the occurrence of venous thromboembolism. Possible side effects include menopausal symptoms like hot flashes or night sweats, as well as leg cramps, and this is believed to be related to having an estrogen-like effect in terms of causing those vasomotor symptoms. It can be considered in those who have particularly low T-scores in the spine as compared to the hip, or those who are at high risk for breast cancer related to a family history of breast cancer.